Thanks, you guys. Wow, fourth day. I'm sorry. I'm so sorry. But you know what? When you go back to your offices and you start talking to your friends and your colleagues and they start saying, "What do you do? Do you practice medicine still?" And they look at you with that curious face, you can say, "Absolutely," with renewed vigor and empowerment. The male part of this is a whirlwind kind of sampler platter of what the other module really has become, which is more of a men's health. This is talking predominantly about testosterone replacement and testosterone sparing options for guys that have low T at various ages. We get into this in a level of detail in addition to prostate health and other chronic prostatitis subjects much more in detail in the other module. So without further ado, let's get started. The objectives for the next 75 minutes are really, I'm trying to make this as pragmatic as possible because I, like you, practice still and have to make this real. We want to talk a little bit about some of the deficiencies, what the definitions are, the prevalence. We're going to talk a little bit about what maybe changes the prevalence rates of testosterone deficiency and how it relates to aging. Next, we're going to talk about some of the causes and some of the physiologic impacts, some of the comorbidities associated with low T. We're going to talk a little bit, just again, a little tease on actual monitoring and lab assessment, in addition to how to come up with the diagnosis using physical exam, medical history, and clinical signs and symptoms. And then lastly, we're going to talk just briefly about how to develop a plan. What do you do? So the naming has become a stumbling block. When you start to study this area, you've got hypogonadism, you've got adult onset hypogonadism, late onset hypogonadism, partial androgen deficiency in the aging male, which has got its own acronym. It's kind of crazy. Really, the only thing you need to remember is testosterone deficiency, but let's back up and kind of come forward to that before we move on. You and I learned the classic scheme, primary and secondary. Primary low T is where you've got low T, and it's associated with usually an exaggerated response from the brain, either the hypothalamus or the pituitary, and the testicle is just kind of not responding anymore. And that's kind of the classic scenario. The Klinefelter syndrome, the XXY, the genetics. You've got mumps orchitis, so infectious causes. You've got radiation, chemo, infarcts, trauma, all kinds of things that can lead to not having a response from the gonad. You've got toxicity issues that can be involved that are more acquired. We talked a lot about with Dr. Luby's environmental thyroid talk, and this is not to be missed on this topic either. It's another hormone that's affected by the environment dramatically. And so things like cadmium from secondhand smoke, believe it or not, can lower T. And then there's secondary. Secondary is the more common of the two. If you take all people, guys, that present with low T, 85% have secondary hypogonadism or low T. The other 15% are usually the primary. And there's some other groups that compensated and some others that have come up. European male aging study that we don't get into in this talk as much, that makes that not quite as black and white. But secondary is where you've got low T and you have an inappropriately normal LH or gonadotropin releasing hormone response. It can also be low. So if you think about it, when things are not adequate, when testosterone is not around in sufficiency, the brain should be telling the boys down below, hey, get going, make your stuff. And when that's not happening, we call that secondary. And you've got all these common causes here, some not as common as others. There's a hypothyroid. Primary hypothyroid can lead to a secondary type of low T. And that's what Joel was talking about, how these hormones talk to each other earlier this morning. Wasting diseases, things like HIV, people on medications, things like cimetidine and TCA antidepressants, things like nicotine, too much alcohol can actually suppress. And then you've got things like pituitary adenomas, which are pretty rare, but you need to know that that is a common cause of secondary hypogonadism when you get down to some of those zebras. What's interesting, you heard me say earlier that 85% of all people coming to your practice that have low T, the men in this talk, are going to have secondary hypogonadism. Of that 85%, 89%, we have no defined specific medical cause. Clearly, the majority of people that we see in our practices, they're going to be secondary, and of those, we don't have any idea why it's low. And this is the group that really fits in nicely with a functional medicine provider discussion, because it's all about environment. It's all about lifestyle. It's all about the comorbidities. And you're going to hear me drone on about comorbidities quite a bit. The International Society for the Study of the Aging Male back in 2016 came out with an expert consensus that said, look, these symptoms and signs of low T, they're real, and guys benefit whether we know the cause or not. And that flies a little bit in the face of the current guidelines that some of the other people are publishing, in particular when you look at indications by the FDA. They want to know that it's from the brain or from the testicle, end of story. Well, if 89% of them, we don't know what that is, wow, already you're kind of at odds. These expert panels kind of help us, and the AUA has come out with some statements that are similar. So, what is the influence of testosterone? It's vast. We've got influences in the brain with libido and cognition, in the muscle with not only the amount of muscle but the strength that's there. It stimulates the erythropoietin in the kidney. It stimulates the bone marrow stem cells directly. It's involved with accelerated linear bone growth. It's involved, of course, with male sexual reproduction, sexuality, and liver synthesis of different proteins. I mean, that's not something I thought of every day. The other stuff's more obvious. Skin, yes, it's involved with collagen, just like growth hormone. Growth hormone and testosterone work together to do things like promote collagen, to prevent the breakdown of protein, and to promote fat breakdown, lipolysis, as opposed to lipogenesis. So we get increased collagen production. It's an interesting phenomena that we have now really settled on. And this little white paper from 13 now, 6 years old, from the AUA kind of puts it in succinct. It says, look, we got all these non-specific symptoms of low T, kind of like with hypothyroidism. There's all this overlap. And we really need to verify it with not just signs and symptoms that can be indicative of other diseases, but we need to make sure there's also an abnormal lab that's persisting. It's not just one day where they have a fluke amount of stress, or they're on one of these medications that suppresses it, or they're malnourished, because we know we can have acute abnormalities. We need to confirm it at a second day, and we really need to have it kind of jibe with a history and physical. So these are the three components that we're going to talk about in a couple slides coming up. But the AUA agrees there's really no, this is an interesting thing. Think about this. There's really no accepted, universally normal threshold of T that distinguishes guys that are eugonadal from having a problem. And so this is why just simply using a range of 300 to 1,000 nanograms per deciliter in a bubble can lead you in a dangerous place. I've got guys who feel horrible below 800. And I've got guys who at 390 feel great. They have zero symptoms, zero signs, and they have no physical exam findings. They don't have problems with DEXA scans showing osteo. So you really want to couple these three things together. And for this talk, we're going to call it testosterone deficiency. We don't like the term hypogonadism because that refers to low sperm counts and fertility, low androgen production, and all of the rest. It's not specific enough. These are the three things. This is an anchor slide. What do you need? You need signs and symptoms. You need a low T that's confirmed on a second day. And you need a physical exam history that kind of makes sense with what you're thinking. So, moving on. Again, this is looking at the International Society's consensus. In 16, they're saying, look, this is a well-established problem. It's not only associated negatively with male reproductive health and sexuality, but it affects guys' quality of life. By the end of this talk, I hope that you see that it affects a whole lot of stuff that we end up spending our time with during the day, like prediabetes, insulin resistance syndromes, obesity, and cardiometabolic disease at large. But having a low T predicts and is an independent risk factor from things like an elevated BMI, diabetes, metabolic syndrome, contributes and predicts for low bone density. It is also a problem with sarcopenia and loss of fat-free mass. It's associated with not only cardiovascular mortality being high when it's low, but all-cause mortality. And again, this general health takes a hit. So this is a study that shows back in 14, kind of looking at all comers, prevalence of low T. And they did not stratify this as to, were these guys symptomatic? Were they presenting for other reasons? This was just looking at the labs. And you can see by the time a guy hits, 45, over a third of them already have a problem with low T. What is the relationship between testosterone and aging? And if it seems like I just jumped from what you guys just did to something unrelated, bear with me. It's complicated. That's the answer. That's the easy answer. Around 0.3 to 1.5% decrease after your mid-20s is kind of the dogma of how T declines about that rate. The problem is that if you take into factor the comorbidities that are associated with aging, it appears that a lot of that testosterone decline that appears to the casual observation as simply due to age, you lose some of that association. In fact, the male age-related decline can often be explained by, Dr. Luby, environmental, thyroid, now here we are on testosterone factors. We call them comorbidities. That's just a fancy way of saying lifestyle-related diseases, most of which we know in this room are related to poor choices. So, BMI, having too much insulin around, pre-diabetic syndromes, smoking, marital status, who knew, stress and sleep. These things are actually more tightly associated with decreasing T than if you take the data decade by decade and simply look at the association of TD with age alone. So, testosterone deficiency doesn't really equal an andropause scenario. In fact, there is more statistical data showing a tight correlation with comorbidities over age itself. So what does this translate to? Don't miss low T in your younger guys, and don't assume every old guy is low on T. It's not that simple. You got to look at the field which in this guy is operating. The second objective is to kind of look at what happens with diminished T physiologically. We've got all these associations, and we've got all these things that are impacted by low T. And in lots of them, we don't have good RCT trials that are large enough and powered enough to put causation. So most of what you're going to hear me say about low T and physiologic problems has to do with associative correlative data. That being said, the arrows often go both ways, meaning, for example, obesity propagates low T propagates obesity. The same could be said with things like diabetes type 2. So, obesity, there they are. And you've got other things that are associated with TD, like environmental problems, fragmented sleep, stressing out, both psychological, physical, all of the above, meds, low thyroid, toxicants, biotoxins. We don't talk a lot about that in this talk, but certainly mold mycotoxin and Borrelia have a huge role centrally with leptin reception in the hypothalamus, mast cell activation, and thyroid is only one of the things that gets screwed up by environment. Testosterone, due to LH production getting messed up centrally from those kinds of infections, also can be a problem. Tumors, genetics, infiltrative diseases. Most common mutation in Caucasians is hemochromatosis. So one of the labs we look at when we identify somebody that's got a confirmed low T is ferritin. We want to see if they've got one of these infiltrated processes. And that can occur at the testicle level or in the brain. There's higher rates of these insulin-resistant, leptin-resistant metabolic syndrome patients that unfortunately we're seeing in epidemic proportions walk in through the door. Of course, bone loss, low muscle mass, mood issues, inflammation. How many of you knew that rheumatoid arthritis, Crohn's, psoriasis has a high association with low T? It's in the literature now. And of course, sexual and reproductive dysfunction, which most of us knew already. Putting it down on the timeline in the matrix, I love putting these things down because it forces me to be complete. I don't know that I would have thought of, some of these things and made these connections with a lot of the patients walking in had I just gone to the labs, gotten a quick history. So ask them about sleep. How are they handling stress, and not the fact that they have it, but how deep is it coming in, and what are their tools to deal with it, as we heard this morning. Energy issues. Of course, if you've got problems with insulin resistance and thyroid function, we know that these endocrine glands all talk to each other, and we know there's this hierarchy of adrenal, thyroid, and then sex hormones. One of the things I've noticed in the last 10 years since working the matrix or working the root cause direction, my prescriptions for bioidentical hormones for men and women have dropped precipitously. I find that I don't need to write very many prescriptions anymore for bioidentical hormones. The ones that need it, sure. There's still those that out there that need it. But the quantity of those prescriptions dramatically drops when you start working these other nodes of imbalance that you guys have learned about. Talking about those arrows going both ways, there's this bidirectionality of low T and obesity and metabolic syndromes. And so when you see low T, it's a biomarker for ensuing cardiometabolic badness. Okay, that's a very scientific term, by the way, badness. Of the 89% of the 85% that have secondary, the 89%, they have no known cause. Full 70% of those have either obesity, diabetes type 2, or met-sin, or all of the above. This is the bulk of the guys with low T. They have cardiometabolic disease. And this is why I say that low T is just another Framingham risk factor that's not been made official. This is a biomarker for cardiovascular disease and cardiometabolic illness. Expanding on that point, up to 40–50%, depending on the study you read, of guys with type 2 diabetes have testosterone deficiency. Couple of mechanisms, both surrounding really having too much adipose tissue. One of them having knowing the fact here on this graph, and this is a graph to actually bring out and show patients, and they get it after they see this little cartoon to the right. If you've got too much adipose tissue, you're making more leptin, because that's where we know leptin's made, usually in the visceral fat, that white inflammatory fat. And you make these inflammatory cytokines that directly inhibit at the level of the testicle and at the brain the production of T. Also, more adipose tissue leads to increased aromatase. So you're getting more estrogen, which has that negative feedback at the hypothalamus, shuts off LH, and there goes your T. So kind of the double whammy effect. What's interesting, and if you guys don't remember anything from my part of this whole week, it's this slide right here. Visceral adiposity, low T, and hormone imbalance in general and insulin resistance are really kind of the same disease. It just depends where you look in this chicken wire in this diagram. Increased visceral adiposity leads to more aromatase activity. We know that with age and with hyperinsulinemia and stress and leptin, all of those things upregulate aromatase. And so you're going to make more estrogen, which I just mentioned decreases from the brain level T production. With decreased levels of LH comes decreased testosterone. We know that as T drops, a very insidious little enzyme called lipoprotein lipase activity goes up. And what does it do? It increases triglyceride uptake by the fat cells. So they get bigger and bigger and bigger. They get hypoxic. They get mad. They start sharing their bad attitude and spewing cytokines like TNF-alpha, IL-1 beta, IL-6 systemically. And this is what you heard earlier in the week where it talks about adipose being not just the storage of energy, but now it's this other endocrine gland, which can be a real problem child. So once that leptin and those pro-inflammatory cytokines start getting spewed out of this increased abdominal fat mass, you get more negative feedback to T, both at the brain and at the testicle. Increased fat mass, more inflammation, more insulin resistant, more fat, more estrogen, and on it goes. So finding a way to jump in and disrupt the cycle is really what your job is in most of the people that present with low T. There's a few with primary, which is a different discussion. So when we address low T, we really kind of go after metabolic syndrome. There's 5 criteria, as you know. And as you treat guys with low T, there's great data that shows that you improve insulin sensitivity, which is one of those 5 criteria for MetSyn. You improve body composition by discouraging fat from accumulating viscerally in a predominant way. And in fact, studies have shown that the total body fat mass doesn't necessarily change. It's mostly that white fat, not the brown fat that's the stuff we do the liposuction away that's sub-Q, that has a lot less ramifications health-wise. And then also treating low T, you get a better lipid profile. What about sleep? Well, we know that sleep apnea is related to low T. In fact, there's this inverse relationship to severity. The more severe the obstructive apnea, usually there's a correlation with a low T. We know that it's not a direct correlation because when you give people with apnea CPAP, their testosterone, if it's low, doesn't necessarily always respond positively. But we do know that it is a great marker when T is low to suspect that possibly you've got a severe case of OSA going on. Sleep in general is really, really important. Why? Because it's only really when we're sleeping and we reach that first REM cycle and we get into deep stage 3 and 4 delta sleep through the night that we're pulse dosing testosterone and growth hormone. So when you're doing things like Ambien and medications that distort REM architecture, you're unconscious, or even drinking, because you're stressed and you haven't dealt with it and you're doing that to knock yourself out, you're really not going to get the restorative hormone pop that you would with a normal REM, a normal stage 3 and 4. We know that just within a week of getting 5 hours or less sleep, young men drop their T by 10 to 15%. I'm glad I didn't know that in residency, because that was the norm on a good night. So this is, speaking of residency, this is a study looking at psychosocial stress and sleep deprivation at internal medicine residents, and those guys got nailed. They and the general surgeons, they were always up. Comparing to age-matched males in the hospital that were not residents, they had a much lower level of T. And we know that it decreases free T independently from other confounders like BMI, smoking, drinking too much, or having a high waist-to-hip ratio. And in fact, just after 5 days in this paper, the urinary free cortisol went up by 81%. And in fact, the plasma went up as well with cortisol, with a concomitant significant decrease in plasma T. So stress is just bad for everybody, including guys. Here's how we think it works. This is a study out of Berkeley that was done. Basically, there's this thing called gonadotropin inhibiting hormone up in the hypothalamus that blocks the releasing hormones so that it can never get to the pituitary and make LH. And it appears to be a dose-dependent response. Again, we're talking about chronic unrelenting, not jumping out of the way of the speeding bus. We're not zebras, right? We learned that this morning. So, depression and mood. We don't have enough data yet to say that there's a causation between depression and low T, but we've got great studies, lots of trials showing that if you improve T and optimize it in guys with the foul mood, they get better. And in fact, they get less irritable and they have a better quality of life. Meds are an issue. You know, a lot of us know about things maybe like tricyclics and the older antidepressants affecting it, drinking too much, smoking, but chronic pain meds are a huge problem, not just for the whole opiate thing that we're all dealing with, but because it lowers T dramatically, as do folks that are on catabolic steroids. Cannabis, that's another talk. The advanced practice module, we talk a little bit more in detail about that. The jury's still out on what cannabis actually does, and looking at, you know, which, is it THC, is it one of the other products, does the CBD, is it hemp, what is it? But basically what we know is that in the newer studies, it's unclear what the relationship is with testosterone and cannabis in general. Sperm, another quality. That's another issue. It causes huge problems, and I'm very concerned about what we're seeing in the uptick in use for all the different justified reasons, and fertility, because fertility has already taken a 40% hit in the last 40 years. We have no room for error with that. So just a word on that as a teaser. Yes, anabolic androgenic steroids. The guys that are abusing those, they can create a permanent secondary low T doing that. Statin drugs are implicated. The effects in some are nominal. On average, if you look at the meta-analysis, which is going to be coming up here in the next slide, it's less than some people might think. And then, of course, chemotherapy is directly toxic to the Leydig cell. Here's the meta-analysis on statins and what it does to T. On average, about 12 nanograms per deciliter drop in testosterone with most of these studies looking at therapeutic doses. I will tell you in my experience that there are men who have profound effects with statins on testosterone, and then there are guys who it doesn't seem to really make a difference. So like we heard this morning, test, don't guess. Opiates, another story. Huge problem on inducing severe levels of testosterone deficiency, and not just promoting psychological problems, but also issues with fatigue, anemia, and quality of life. And when we look at the meta-analysis associating opioid use and testosterone deficiency, it's a huge problem. About 75% with chronic pain meds, and I'm talking about Norco and Vicodin, guys, not necessarily the big guns, have low T. You start checking these people who are on, you know, Norco a couple times a day for their lumbar problems, their testosterones are almost universally in the toilet. It's unbelievable. And we know that it's a dose response. The mechanism is inhibitory, not unsimilar to what we saw with the stress. Opioids act the same way by inhibiting at the hypothalamic level. And it does also seem to be dose dependent. So getting them down on their opiate requirement can really help low T. So this is why we talk about the soil in which the gentleman presents himself being important. I can't tell you how many times I've heard driving to work the ads on the next greatest testosterone supplement that you need to run out and buy, and these clinics that are popping up everywhere because it's such a big deal. And I've made a practice receiving and doing damage control and getting a lot of those people into my clinic who are frustrated, and they're just not addressing any of this background or associative data, which is huge. It's 89% usually of the guys that have low T are in that area. So these are associations we talked about, keeping those in mind.